everyone. I'm Dr. Karmon from the Fertility Institute of Hawaii. Dr. John Frattarelli will be joining us in a few minutes as well. So I just want to get started. Today we're going to be talking about genetics and fertility in general. So that's going to include talking about something called genetic carrier screening, as well as PGT-A and PGT-M, or pre-implantation genetic testing. While we talk, I definitely would like you guys to interrupt me with questions and comments, and I'll be able to kind of go through and answer any questions that you guys have. So the first thing that I want to mention is chromosomes versus genes. So in a very, very basic way, obviously genetics are the makeup of us. Our genetic code are what determine a lot of things about us. And each gene is kind of typically associated with some type of expressed phenotype. And our genes are all kind of structurally intertwined in a structure called a chromosome. When we do genetic testing, we could either be looking at the structure of the chromosomes, or we could be looking at issues in a gene. So, for example, a very common genetic condition is called cystic fibrosis. That can create lung issues in people who are impacted. All right, cystic fibrosis is a mutation in a particular gene. All of us typically have two pairs of each gene. In a recessive gene, in a recessive mutation, one gene will be impacted by mutation, and that will typically not affect the person who is a carrier. If they only have one gene, they're called a carrier. If they have two mutated genes, then they're affected with the disease. Okay. However, if there's an issue with the structure of the chromosome, or somebody has too many or too few chromosomes, that is a disorder that is going to be associated with an abnormal karyotype. And the most common famous ones would be conditions like Down syndrome. Okay. Mutations in genes are usually inherited. So if I have cystic fibrosis, or if I'm a cystic fibrosis carrier, that means usually that somebody in my family was a cystic fibrosis carrier, namely my mom or my dad, and they passed it down to me. Down syndrome, however, and the disorders with karyotypes are a little bit different. Okay, Down syndrome occurs when somebody has too many of chromosome 21. So they actually have a third copy. Instead of the two pairs of chromosomes, they'll actually have a third copy. And that's what creates the health issues that are associated with Down syndrome. Down syndrome is one of the famous karyotypic abnormalities because it can be associated and compatible with live birth. The majority of other chromosomal disorders are not associated with live birth, or not things that a baby could be born with or survive. So oftentimes, if you conceive a baby with this issue, you would potentially have a miscarriage, or the embryo just simply would not implant. Now, these disorders, the karyotypic disorders, are usually not inherited. They're usually mistakes that are made during egg maturation, or while the embryo is ongoing in terms of development. So these karyotypic abnormalities are usually associated with age. So I would not be able to test you as a patient and tell you exactly what your risk is of having a child with Down syndrome before you're pregnant. Okay, I can tell you some probabilities based on your age, okay, or factors like that, but but ultimately, whether or not the child has Down syndrome is kind of determined after egg maturation and fertilization. This is different than the abnormalities that occur in genes, which I mentioned I can test you for and see if you're a carrier for a particular condition, and then that will essentially determine what the risk is if you're having a child with that particular condition. So, genetic carrier screening is typically a panel of, it's blood work, which tests for a panel of genes, and that will tell us what you are a carrier for. So again, that's going to test you for things like cystic fibrosis, spinal muscular atrophy, as well as the other conditions, some which are rare, some which are more common. We're being joined here by Dr. Frattarelli. He didn't want to leave me by myself.
Sorry about that.
Also Fertility Institute employee. But yeah, so just so I can finish. So what I did so far, just to update you, I updated everyone on difference between chromosomes versus genes. We just talked about some structural things. And then I started getting into genetic carrier screening. So just talking about basically what it is. Again, we're testing you to see what genetic conditions you may be a carrier for. Okay, when you do these types of commercial tests, we are usually testing you for the recessive conditions. So you're not going to get back a test usually where I'll say, wow, actually you have a terrible disease that is going to kill you in some time. Okay, that's not going to be the result that you get. The result that you get is going to tell you whether or not you're a carrier for a particular condition, which if your partner is also a carrier for that condition, your child then has a probability of being affected by this disorder. Okay, so there are a few different kind of things that need to happen before you really need to worry, so to speak. And even then, you don't need to worry. We'll get into that. But the pros, I think, of doing this type of genetic carrier screening are that it gives you the information ahead of time. It's going to tell you, what your risk is of having a child with this disorder, and then you can decide where to go next with that. Okay, the cons are them can be expensive, or they can reveal results that may worry you essentially for not very good reason, because and sometimes these disorders are not even very, very serious or severe. So I think those are really the pros and cons to BALS. If I didn't mention, they are done with blood work. And so that part is very simple and easy to do.
And I just might add a little bit to that. I think it's important to realize that we all have recessive genes. So what we're looking at when we do the carrier screening is, do you have a recessive gene that may end in a baby having a genetic abnormality? And it's estimated that probably about 1 in 30 to 1 in 50 couples that will come into our office. So again, male and a female, or a sperm and egg, can have the same chromosomal genetic abnormality. Some of these are very mild and very, very rare, and so they're not all going to necessarily be selected against. There are some that you might say, well, it's something like like diabetes or hypertension. Those aren't the disease that you're looking at, but it's something similar to that. This is kind of a lifelong issue that can easily be treated, that you just are aware of, and makes you aware when the child is born that potentially there's something that needs to be treated along the way. So it's not necessarily something that you would always select against. However, like Dr. Karmon said, there are some that you definitely would want to, like cystic fibrosis and things like that. And so that's important to realize. And I think a lot of times patients do get a little concerned when they have 3 or 4 recessive gene abnormalities that there's an issue, but it's not. It's very common if the sperm or egg partner has the same genetic abnormality.
Right.
And then I think we're going to talk about PGT next. So
yeah.
So pre-implantation genetic testing is what we do on embryos. So different than the carrier screening where we draw blood from you. With the embryos, what happens is we get the embryo, or we get the egg, fertilize the egg, let the embryo grow in the lab till the day 5 or blastocyst stage, which sometimes day 5, day 6, even day 7. And then we do a biopsy on the cells that would normally become the placenta. We're not testing the cells that become the baby. There's 2 sets of cells. One's called trovectoderm cells, and one's the inner cell mass. The inner cell mass becomes the baby. We can't take cells from that because we might be taking cells that would become the arm or the heart or something like that. So we leave those cells alone. But we can take a few cells from the placenta and not harm the embryo whatsoever and get a result that tells us if that embryo is chromosomally normal or not. I find this very fascinating because when we draw blood from you or from me or from Dr. Karmon to get the same result, we're getting millions of cells to get that result. And from an embryo, we're taking 3 to 5 placental cells and getting the same result and getting a very accurate reading from that result. And so from that result, though, we just know it's chromosomally normal. And as Dr. Karmon probably said earlier, the chromosomes, they're all paired up, okay, with the exception of either 2 X's or an X and a Y, depending on the gender. And just making sure that everything's paired. And if something is not right, if you have 3 of one or you're missing one, most of those do not end in a live birth. There are a few that do. Down syndrome, most common one that people realize. There's also some sex chromosomal abnormalities that end in live births where adults are very functional. But then there are some chromosomal abnormalities that not only would end in a late-term miscarriage, but a live birth that potentially could, where the baby would expire very, very rapidly, very quickly. So those are things important to know.
I think it's important to note as well, because sometimes we do this testing and people are very surprised that out of 10 embryos, they have 1 or 2 which are normal. And how could that be? So, oh my gosh, I was going to have 9 kids with these severe abnormalities. How's that possible? The truth is, interestingly, although most embryos seems like they're chromosomally abnormal, most children are normal. And so it's not surprising at all, to us when we see various degrees of chromosomal abnormalities or aneuploidies. And that's because usually those abnormal embryos won't implant. So I tell my patients, if you chose not to do this testing, then what would have happened is we would have transferred that embryo and most likely it just wouldn't have implanted, or it would have ended in a miscarriage. It would be uncommon for it to implant and then result in a child with an abnormality similar to Down syndrome. Of course, it does happen and there are children with chromosomal abnormalities, but most of the time they will miscarry or just simply not implant. And so that's why you see that big difference in terms of PGT results versus real life. And when you actually meet children, you realize most are normal.
Yeah, no, that's very important to realize that as humans, I always tell my patients, as humans, we do not reproduce very well. Okay, other animal species, mice, almost every egg makes a pup almost. So it's as easy as mice to reproduce in other species. As humans, depending on the age of the egg, it can take 10 to 20 to 30 or 40 eggs really before you get a baby. So when you're in your 20s, typically it takes about 8 to 10 eggs to make a baby. When you're in your early 40s, it takes more than 20 eggs to make a baby. And that's because not every egg fertilizes. Some of them will fertilize abnormally and cause chromosomal abnormality. And like Dr. Karmon said, those embryos typically just don't implant. You don't get pregnant, or you have a very, very early biochemical pregnancy and never even know you were pregnant. And so even though we're seeing these abnormalities with the chromosomes, we're really just selecting out the embryos that would not have made it to the positive pregnancy test in the first place.
And also, the other thing related to this, sort of indirectly, right, speaking of us not being very good at reproducing, is that even in your peak reproductive years of your 20s or early 30s, you're going to see natural fecundity of about 20% or so per month. So if you have no fertility problems whatsoever, your chance for getting pregnant, this varies by age, but let's say you're young, your chance for getting pregnant without any fertility troubles whatsoever is going to be about 20% per month. And the thought is that, a lot of that, it could be related to a number of issues, but a lot of that is probably the fact that not every egg is meant to be. And when we do in vitro fertilization and we get, a handful of eggs, we see that. We see like, okay, not all these eggs were really ever going to result in a live baby.
I guess, also just kind of back up a little bit, we were talking about genetic carrier screening before, when you're looking at an abnormal gene that the sperm and the egg may have that they would pass on to the embryo. When you do pre-implantation genetic testing, you can then test for that. So there are different things that we look for when we do PGT or pre-implantation genetic testing. We're looking to make sure the chromosomes are normal if the genetic carrier screening was normal for that couple, or for the egg and the sperm. If there was a gene that we have to specifically look for, again, like thalassemia or like Tay-Sachs disease or cystic fibrosis, then what has to happen is a genetics company needs to build a probe for that gene, for your specific gene. So they would get blood from typically from you and from your partner, and even some family members. And the more specific they can build that probe, the more accurate they can be to actually then look and make sure, does that embryo have that cystic fibrosis gene or Tay-Sachs disease or some other abnormality that they're looking for. We are not at this point where we can look at an embryo and do PGT and look for all those chromosomes, all those genetic abnormalities that we would look for if we did a genetic carrier screening for us. That is not available at this point.
Yeah, and then I think something that's been coming up more and more is this question of mosaicism with PGT. And so if any of you watch this, you may have had these results, and it is tends to be controversial on how to handle this. Okay, so mosaicism by definition is where some of the cells are chromosomally normal and some are not. So remember, we're sampling a few cells, not a whole lot, but 3 to 5 cells from the trophectoderm. That's the outer layer of the embryo, which later on differentiates and becomes part of the placenta. We're sampling a few of those cells, and the typical results that we've been used to are either normal or abnormal, but now they're sort of in between, where some are normal and some are abnormal. Various labs will have different cutoffs regarding high level or low level mosaicism. But for example, if one cell is normal but the rest are abnormal, well, that seems more likely to be kind of an abnormal embryo. But if most of the cells are normal but one is abnormal, well, that's more of a low level mosaic, right? And so the question is, do we transfer those mosaics? And I think that it depends on a number of different factors. Want to talk about it a little bit?
Yeah, so I guess
chance to shine here.
It's really evolved and it's really changed. I think when you look at with the evolution of PGT, started in the 1990s, where we would look at 1 or 2 chromosomes and just that's all we could look at, and then it evolved to where in the 2000s where we could look at all the chromosomes, and now it's gotten where we really get it's gone from like black and white TV to color TV to high definition to whatever the next step is going to be when we're looking at chromosomes. So we see so much more detail now, and before we couldn't pick up mosaicism. We couldn't pick up small deletions or small insertions or small duplications that we actually can see now, and that brings up a lot of questions that we have. And I think initially the thought is abnormal is abnormal. And so you don't use it. And so you use the normal embryos, and then all the others are just abnormal. I think these days what we're looking at is you have abnormals, you have normals, and then you have things in the middle, which are typically the mosaics, or the most common ones. And you use those last, typically, if you're going to. And when it comes to counseling patients, basically what I tell them is that it's like we don't know. It's like we didn't test the embryo. Because we don't test embryos on everybody. And if you didn't test the embryo, this is a good-looking embryo, you would have put it in. And the reality is we don't see mosaicism syndromes. I mean, that's always the concern, is that you're going to put an embryo in that has mosaicism, and you're going to get some mosaic syndrome that's out there that, yeah, if you do a literature search, you'll find that it's found in 1 out of 400 million children or something like that. But the reality is we don't see it, and we're putting them in because we're putting embryos in that aren't tested. And so we know that they're there. And so if someone has an embryo that's mosaic, we talk to them, we do a literature search, we have them talk to a genetic counselor as well. But the reality is, yeah, you certainly can use the embryo. And again, I just tell patients, it's like you didn't test the embryo. It's like you don't know, or you know everything that you do know. So typically, it's going to be a normal female embryo, but it's mosaic for trisomy 8, so 3 8 chromosomes on some of the cells, right? And so all the other chromosomes are normal. It's just the 8 chromosome you don't know about. And so that's just generally how I counsel my patients, and then we to use it or to not. So, after all the counseling that we've done. Is that similar to what you do, or?
No, I do something totally different. Okay. No, I'm just kidding. I do exactly that. That's what you're supposed to do. What he just said. That's totally what I say, right? Okay. I just want to interrupt this topic because we do have a question from somebody live here. So, and she's asking, do you only test the genetic mother, or is the genetic father also tested, I assume, with genetic carrier screening? So like two parents having the recessive gene for disorder mean the baby will for sure have the genetic disorder, but if only one parent carries a recessive gene, only have a certain possibility of having the genetic disorder. So that's a great question. Just jumping back we'll jump around a little bit, jump back to the genetic carrier screening, which again, remember the genetic carrier screening is when we test the blood of the intended parent, okay, or the genetically linked person. So typically we can test kind of one patient first, right? And that could be the male or the female. And then if that person is a carrier for the condition, then it's good to know if the other partner is also a carrier for the condition. Then we would also test the genetic father. If both, or mother, right? Doesn't matter which one really tests first. If both the genetic mother and the genetic father are carriers for the same condition, then the affected child has a 25% chance of being affected. Okay, this is in a recessive condition. There are some disorders that are more complex. There are crazy genetic conditions called, anticipation, and there are all kinds of other things that are a little bit more complicated. But for most recessive mutations, yeah, we would recommend testing the genetic mother, genetic father, and then that will determine the risk for having a child with disorder, which is typically 25%. Now, if just one person is a carrier, then the child is not at risk for having the disease. Okay, they are at risk for being a carrier for the disease. Okay, but again, being a carrier usually means that the child will not have any health conditions typically associated with it. By definition, usually a carrier just means that although they have one abnormal mutation, they're otherwise phenotypically healthy. So I don't know if that kind of answers the question, but yeah, we usually will test one partner first, and then we would test the other partner if the one partner is a carrier. Right. And then depending on the panel and how large the panel is, more than half of patients are carriers for something. So I want to reassure most people that, yeah, like it's not a big deal if you guys are carriers. Most people are carriers for something.
And the reality is, if we checked everything, we're all carriers for something. And so what I tell my patients is, if they're a carrier and the egg or sperm source is not a carrier, that worst case is that the child ends up being a carrier just like they are. It doesn't affect them because it's a recessive disorder, and unless when they go to reproduce in the future, then that would be something they would need to look at. But who knows what medicine's going to be like in the future? It'd be a lot easier than it is now, probably.
I guess we can touch on some of the dominant conditions. One of the kind of more famous ones is BRCA, for example. So having a BRCA mutation puts men and women at higher risk for certain types of cancer, especially breast cancer and in some cases ovarian cancer. And so Some patients will want to do genetic testing specifically of the embryos, specifically to avoid passing this condition on to their offspring, even though they themselves have it and they themselves are at higher risk. So BRCA is one of the dominant conditions because just having one copy will confer a higher risk of breast cancer in the offspring. Okay, or for the person themselves. And so in those kind of cases, right, if you come in and you know you're a BRCA carrier, there's no reason necessarily to test the partner. We already know that your offspring are going to be at risk for this condition. The genetic carrier screening that we do in our office, like I said, does not test for these dominant conditions, of which there are many. However, we're not testing for them. And there are a number of reasons for that. Oftentimes the idea is that, well, if you're a carrier for a dominant condition, you should know that already because you should presumably be sick. But the other thing, for example, things that are more subtle like BRCA, the point of this testing is to look at reproductive risk in the offspring. We are certainly not here to diagnose serious conditions like that by just doing these large panels. So I know some patients have approached me and said, I'm really afraid of doing this genetic carrier screening because I'm scared that something is going to come up that I don't want to know about. And so I explained that that's really not the type of testing that we're doing when we look at the recessive mutations. We're not looking for those dominant conditions. And I'll also just say, somebody asked, where are you guys located? We are located in Hawaii. If you are in Hawaii, we're in the Halepawa'a building on South Veritania Street. We're downtown, very conveniently located. And we have a number of other satellites. We also travel to the neighbor islands, COVID permitted, but for now we are, right? We still are? Yeah, we still are, okay. And yeah, if you want to.
So I guess, one of the questions that always comes up is cost. How much do things cost? And that it varies. If for the genetic carrier screen, I don't know if Dr. Karmon mentioned this before I kind of came in, but we look at your insurance. We work with the genetic carrier companies to see which insurance they work with. And most of the time, the out-of-pocket cost is no more than like $200 for those tests, whether your insurance covers it or not. For the for the PGT testing, depending on what you're doing, if you're doing it for a genetic reason, we're looking for cystic fibrosis because you're both carriers, for instance, for cystic, then we sometimes can get the insurance company to cover that because having a child with cystic fibrosis is obviously a very difficult thing for a parent for their entire life. But it's also very costly for the insurance, and they realize the bottom line of that it's a costly process. So then it's much less costly for them to pay for the PGT with the IVF than to have a child with cystic fibrosis that they're paying hundreds of thousands and millions of dollars of medical bills for that child's life. And so a lot of times we might be able to get that covered, so we always look for that. If you're doing genetic testing, the PGT, just looking at chromosomal aneuploidy, whether the embryo is normal or not, that typically is not a covered process, and is fairly expensive in the neighborhood of about $5,000, depending on how many embryos you have. If you have less embryos, it's less, or if you have less than 5 embryos, it's less. Most patients have less than 5 embryos. Most patients, I guess, have somewhere between 2 and 8 embryos, I guess, is on average. So it really depends on the patient. We always have an in-depth discussion with you about that and why to do that. And I guess patients always ask me, should I do it? And the reality is, if it's a very difficult question because of finances, and so I can't take the finances out of it. And so what? If insurance would cover this, we would everybody, and that's my answer. So then patients have to decide the financial part. But the reality is, if insurance would cover looking at an embryo to make sure it's chromosomally normal or not before I put it in and it causes a miscarriage on somebody and they have to undergo a DNC or some other medical problem, or it makes sense to not put an abnormal embryo in. It also makes sense not to have an embryo that's stored for 3 years. You've had a child, you have extra embryo frozen, that's stored, and you think that embryo is going to give you a chance to get pregnant, and that embryo is chromosomally abnormal. and you're paying storage fees for that. You have this hope that it's going to work, but it really isn't because you don't know. And so those are kind of issues that we discuss in when patients are trying to figure out should they do it or should they not. But ultimately, it's the patient's decision. It's always your decision of what to do. We're just here to kind of help walk you through the process if that's what you decide.
And then lastly, a good question would be who is eligible for this? And the easy answer is everyone is eligible. But, again, there is some decision making into whether, why you want to do it and how much sense it makes for you to do. Okay, so one of the best things about doing genetic testing is that it helps me pick the embryo, which is most likely going to result in a live birth. So depending on your age, let's say you're 36 and we get 6 embryos. I'm thinking maybe 3 of those are normal, 3 are not. Again, we're just playing with probabilities here. So now I can do a transfer, and typically we like to try to do single embryo transfer. So I take one embryo and I put it in. Well, maybe I pick the abnormal one, but I didn't know because I didn't do the testing. Then we do another transfer. Or maybe I again pick the abnormal one because I didn't do the testing. Then finally I get to that normal one. So now it has had to undergo 3 embryo transfers before I finally was able to, pick that correct one. And had she done the testing, we would have honed in on those embryos right away. Okay. However, let's say we do an IVF cycle and she ends up with just the 1 embryo. Well, in that case, we can still do the testing, but certainly it's not going to help me choose which embryo is best because she only has 1 embryo. And so patients might say, well, it's not helping you pick the best embryo. Why don't you just put in this embryo and we'll see what happens without doing the testing. And that's okay. Now, some other patients might say, you know what, I really would like to do everything I possibly can to avoid miscarriage. I know that chromosomal abnormalities are associated with miscarriage. I really want to do this testing. Or they might say, I'm extremely concerned about a chromosomal disorder in a live-born child. I don't want to have to, consider termination or not. And so I'd rather, even if I just have the 1 embryo, I really want to do that testing. And so I do urge patients, and I always have that discussion, it's not just about whether you want to do testing or not, but depending on how many embryos you have, how many do you want to test? Really, what are your goals with testing? Testing doesn't appear to be harmful now that we're doing it, as Dr. Frattarelli mentioned, now that we're doing trophectoderm biopsies mainly. It doesn't appear to harm blastocyst or embryo development at all. And although it is putting the embryo through an additional intervention, we're sampling cells that would become part of the placenta.
I'll add on that there actually was a really good study that was done that looked at if you have two embryos that you're going to place into the uterus. They biopsied 1 embryo and they didn't biopsy the other embryo. They put both embryos in. And then with the embryo that they biopsy, they could do genetic testing. And then ultimately when the pregnancy came about, they could tell which embryo actually made the baby. And in doing all that, what they found was that when you look at the embryo that they didn't biopsy or the embryo they did biopsy, you had the same pregnancy rates, you had the same miscarriage risk, you had the same live birth rates. So biopsying did not change the outcome of that embryo. I guess one of the questions I get, and I have a question for you. So one of the questions I get sometimes is, I have embryos frozen. Can I thaw them and test them? And the answer is yes, and we do that all the time. As long as the embryo is a good quality embryo, it's going to survive the freezing and thawing and biopsy and refreezing and thawing process very easily. There are some embryos that will say, no, we can't do that for. The reason we can is because the embryos made it to the blastocyst stage, but they may not have had enough of the trophectoderm cells for us to biopsy them safely. And so in those embryos, we'll say, no, we should not biopsy those embryos because we don't want to damage or harm that embryo because it doesn't have enough cells for us to take away some of the cells and then make a good placenta. And then, I do have a question that Dr. Karmon can answer unless she has other things. But one of the other questions I get, and Dr. Karmon I think can answer this better, is I had a normal embryo place, and now I'm pregnant. What test are my OB is my OB going to want to do, and what test should I let them do, since I know I have a chromosomally normal embryo?
Okay. Well, I'm not sure why you think I'd be better at answering.
Well, because you're younger, you're out of residency
Okay, all right.
less time than I am.
Yeah. Okay.
So you remember what the OBs
I remember
do.
what they. I remember what they do because I just did it very recently. Not that recently though. Okay, so the answer to that usually is that you. And there's some caveats, but you should usually do the same type of testing regardless of whether or not you had PGT. That's what most OBs and high-risk doctors are going to tell you. And that's because nothing is 100%. PGT is still not 100%. And there is some question of, well, we're basically biopsying the cells from the trophectoderm, which become part of the placenta. There's some percentage of embryos where perhaps the placenta was normal or abnormal, but the actual fetus itself is normal or abnormal, and that's a type of mosaicism, and that's uncommon and unusual. And we know that from lots of studies that the sensitivity, specificity of PGT is quite good, but it's not 100%. And so for that reason, the testing that's done in pregnancy can have a higher sensitivity and specificity. Now, there's invasive testing and non-invasive testing. Okay, and so the choice ultimately is going to be up to you as the patient and the doctor about whether the invasive testing is really needed in this case. But certainly the non-invasive testing, I think, is something that everybody should be doing in their first trimester as per their physician's instructions. So that includes the first trimester screening, which is some blood work, as well as looking at the nuchal translucency, looking at ultrasound findings, as well as something called NIPT, or the non-invasive prenatal testing that's looking for free fetal DNA. So it's actually now, again, if those come up abnormal, okay, then I think considering doing the more invasive testing, namely amniocentesis or CBS, might make sense. But I think most people who do PGT probably wouldn't jump straight to doing the more invasive type of testing unless there's something in the non-invasive testing or ultrasound that would suggest that was necessary. The other thing to note is that some of the non-invasive testing is also looking at things that we don't test for with PGT. Okay, so for example, translucency, as well as some tests like AFP, which I heard, I'm not sure that all OB-GYNs do that anymore, but those things you may pick up on things like neural tube defects and other conditions which are not going to be picked up with PGT. And finally, the other thing is super important is that PGT is looking at the chromosomal abnormalities, right? And so just like I talked about in the beginning before Dr. Frattarelli here, is that there are lots and lots of genetic issues which are not going to be seen at the level of the chromosomal structure. And that includes gene mutations, as well as certain things we wouldn't be able to pick up on, certain deletions, duplications if they're small. And so all of these things may cause issues that may manifest in certain ways in prenatal testing. And so it's important to kind of routine, do your thing, do your prenatal care, and not necessarily just ignore all of it just because you did PGT.
Yeah, I agree.
Okay, thanks.
Anything else you wanted to end with, or any other thoughts?
No, I think that's about it. I think we answered the questions that I can see here that came up, and then sometimes people will ask questions later, and we can potentially answer those in written form. But yeah, thanks for joining us.
Thank you, guys.
Okay.
Have a nice day.
Have a nice day.